In this next talk, we're going to be talking about different sedatives and analgesic medications. So in this talk, I think by the time you hit the end, you should be able to describe the mechanisms, the pharmacokinetics, and the usual dosing regimens that are associated with different kind of sedatives and analgesic medications. There are 5 medications that we're going to talk about: midazolam, fentanyl, propofol, ketamine, and etomidate. The first 2 meds that I'm going to talk to you about are midazolam and fentanyl. And I've put up there the sort of mg per kg dose, the usual dose, the time to onset, and then about how long that they last. And this is a pretty classic combination of midazolam for sedatives or anxiolysis, along with fentanyl for analgesia. And these medicines have been used a long, long time for sedation, mostly because they're the fastest onset and the shortest duration of any benzo-opioid combination that you can get. You can actually use either one alone, but you tend to need much higher doses, and you don't tend to get people as deep as you often need them to go. So they're usually combined together. Hypotension is pretty uncommon with that combination, but the respiratory depression of a benzo plus an opioid is often pretty potent, so you gotta watch out for that. And really, the only big problem with this actually is that the duration is just way too long for most of the procedures that we do at Emerge. So if you look at that duration, 15 to 30 minutes, 30 minutes to 60 minutes, it doesn't sound like that much, but if you can imagine like doing a cardioversion, it's like a 2-second procedure, and now they're going to be out for like half an hour to an hour. So it's not that practical. And when you have patients that are elderly, that are obese, or patients that have liver or renal failure, this can go on even longer. So sometimes those people are out for multiple hours when all you needed to do was just charge the machine and push the button. And long-lasting medicines is more than just inconvenient. Like, it could actually be dangerous in the right setting. So remember sometimes that a painful stimulus is the thing that's often keeping a patient breathing. So if you're giving somebody midaz and fent and you're reducing a fracture, your procedure might be 10 minutes at most, but the drugs are still in their system for half an hour to an hour. So once you're done your procedure, you're not giving them any sort of stimulation anymore, and that's when they stop breathing. So it's not just inconvenient, sometimes it's really problematic. Some people like midazolam and fentanyl just because reversal agents exist, but I would suggest that it's often safer to just observe the patient. So to clarify, naloxone is the commonly used one with opioid overdoses, and you could use it with fentanyl, but as soon as you give naloxone, you're sort of obligated to watch this patient until you're sure it's out of their system, because you can't have this person sort of get up and walk out and then collapse in the parking lot. So now, instead of just waiting the 30 to 60 minutes for the fentanyl to wear off, you're now waiting the hour or 2 for the naloxone to wear off. And flumazenil is the other one, which is an antidote to any sort of benzodiazepine. But the problem with it is that it can actually provoke seizures. So if it blocks all of your inhibitory stimulation and you're prone to seizures, that could be the thing that sort of sets you off. And if you do have a seizure, you've just blocked all the benzos. So now you've got nothing to give them except like Dilantin and all the other second and third line stuff. So now you're looking at status epilepticus. So it's kind of bad news. Midazolam comes in 1 mg per mil, and fentanyl comes in 50 micrograms per mil. And the only reason I mention that is because these mg per kg doses, I think you can just kind of delete those from your brain. Nobody ever does math with these sorts of things. People typically just dose midazolam as 1 or 2 and fentanyl as 25 to 50. And we usually use units of 1 or 2 or units of 25 or 50 for that. An example of how you might use midazolam would be something like this. So you'd give midaz, 1 or 2 milligrams, and then see kind of how it affects them. And if they look like a little bit loopy or a little bit sedate, then you'd give them a bit of fentanyl and just keep repeating the fentanyl every couple of minutes until they go as deep as you need them to go. The next one I want to talk to you about is propofol. And propofol is one that you'll probably gain quite a bit of familiarity with if you do any ER with us. Propofol is an induction agent that probably acts on GABA. Nobody really knows exactly how it works, but it's definitely an inhibitory kind of stimulus. And it's really the workhorse in emergency department because it's just so short acting. It really gives you good deep sedation, which is very sort of dose dependent. It's very quick and it's very reliable. The only problems with it is that hypotension and respiratory depression are relatively common as far as these sedative medications go, and that's probably just because it puts people so deep so quickly and so reliably. But these effects are also really transient too. So like we mentioned before, hypoxia happens in maybe 10% of people who get propofol, but if it's really, really short, it probably doesn't matter that much. You do need to keep in mind that propofol doesn't have any analgesic effect to it, so it's usually combined with something like fentanyl or other pain medicines to give it that. And the only other thing you need to keep in mind is that it's made with eggs and soy proteins. So if somebody does have an allergy to that sort of stuff, you may have to clarify what kind of reaction there is. And if it's like an anaphylactic reaction, you'd probably want to hold off. If somebody gets a rash or something like that, there's pretty good study to show that it's really not very dangerous at all. The dosing with propofol can be a little bit tricky because there is some variation in how sensitive patients are to the medications. And the general rule of thumb is that if you're an elderly person, you probably need less, and if you're a really small kid, you probably need more. And we also have noticed that substance abusers usually need higher doses, so particularly with alcohol, but some people will say the same thing about marijuana and other drugs like that. At least part of the reason why there's variable sensitivity to propofol is explained by a redistribution effect. And that also explains why propofol is so short-acting. So to explain what this means, if you imagine this is your body and this is your circulatory system, if I inject you with some propofol, it goes right to your brain. And for the time that it's in your brain will be the time that you're sedated, which means that as soon as it starts leaving, that sedation is going to start wearing off. So the half-life of propofol is actually a couple of hours, but the duration of effect that you see when you're sedating someone is just a couple of minutes or a couple of seconds because it just goes in and then goes out. That propofol is still in you somewhere. It's just not really doing anything to you anymore. And this matters because if you're a kid with a really fast heart rate, you might need higher doses to get sedated because it just goes in and out for so fast. And you might not stay sedated for very long because of that phenomena as well. Now, if you're an elderly person at the opposite end of the spectrum, and maybe you've got a bit of heart failure with like a reduced cardiac output, or you've got some narrowing of some of your blood vessels, it might actually take longer than you're expecting for the propofol to reach your brain. So it might take you longer to go down, and it might take longer to actually come out as well. So you might end up staying sedated a little longer as well. To give you an example of how you might use propofol, if you had like a 70 to 80 kilogram person, the usual dose ranges from 0.5 to 1 milligram per kilogram. So you'd usually sort of hang on the lower end of that and say, well, I'll give them 40 to 60 milligrams. And then you just kind of top them up after that bolus with like little doses of 20 every half minute or minute or so to bring them down. The usual advice with propofol is start low and then just go a little bit slower because that'll help you avoid some of the issues with respiratory depression and hypotension and that sort of thing. But you have to keep in mind too, it is possible to go too low and too slow with propofol just because it is so short acting. Right, propofol acts fast, but it also wears off fast. So if you wait too long between doses, that first bolus that you gave is going to be long gone. So, let's say you have that like 80 kilogram male. The effective dose is probably going to be somewhere around 80 mgs to put them down. And if you wanted to be more conservative than me here and you said, well, I'm not going to use a 40 milligram bolus, I'm going to use 20. And I'm not going to use, aliquots of 20 to put them down. I'm going to use aliquots of 10. And instead of waiting 30 seconds, I'm going to wait 1 minute. By the time you get to 80 milligrams, you're going to be looking at 6, 7, 8 minutes will have gone by. And that first bolus that you gave is probably worn off. You're never going to get this guy down with that approach. So it is possible to go too low or too slow with this drug. The next drug I'm going to talk to you about is ketamine, and this is an interesting one. So this is a dissociative medication, and it gives you both some sedation and some analgesia. And it doesn't really give you sedation as much as it just puts you in this kind of weird ketamine trance. So if you've seen people that have been sedated with ketamine, they usually sit there with their eyes open, their eyes bounce back and forth with some nystagmus, and they're often like drooling and salivating. Ketamine is different. So if we talk about sedative drugs and I show you this graph, so if I put across the x-axis just increasing doses of medications, and then I put down the y-axis the depth of sedation, so going from light to moderate to deep all the way down to general anesthesia, most drugs is a pretty linear relationship, right? So if I just give you more and more and more, you'll get deeper and deeper and deeper. But ketamine is not like that. So ketamine's kinetics look a little bit more like this. So initially with low doses, or what people call subdissociative doses, ketamine tends to work more like an analgesic than anything else. Like it makes people a little bit spacey, but you never really get past light or sometimes maybe moderate sedation. And then once you hit this sort of threshold, people very abruptly dissociate and they go right down to something equivalent to general anesthesia. And general anesthesia is probably not a good word for it because they don't just sort of close their eyes and go to sleep, right? They go into this trance thing where their breathing and their airway reflexes are usually all maintained. So it's not really the same thing. And once you hit this point, more doses of ketamine doesn't really do anything. It just sort of drags things out and makes it last a little longer. So examples of how you might use ketamine. So if you just wanted to give somebody a bit of analgesia, you could just give them like a 20 or 30 milligram dose. And if you wanted to sedate someone, most people just sort of go big or go home with ketamine. So you do kind of a 1 mg per kg dose, you round up, and then you just sort of slam it in because you really want to get past that threshold effect on the first shot. If you don't get there, you can repeat the dose, and most people usually just give about half of what they gave already. Ketamine is very popular in emergency medicine right now, mostly because it's just got such a great safety profile. So like I mentioned before, it usually preserves your breathing and your airway reflexes, so respiratory depression is really uncommon. And it also doesn't seem to have any problems with hypotension. In fact, people are much more likely to get hypertensive or to get tachycardic, although that's not always a reliable effect. Why that's not reliable is also kind of interesting. So if I show you this picture of like a neurotransmitter synapse, so the top orange blob is the sending neuron, the bottom one is the receiving neuron. There's neurotransmitters coming out of the sending neuron. They sort of pass into the synaptic cleft, and then they go bind to a receptor on whatever the cell they're trying to communicate with is. Most sedatives act by binding to a receptor somewhere. So they go on and then they snap to a receiving cell and they act just like GABA would, for example. Ketamine also binds to a receptor, but it binds to the NMDA receptor and it blocks that one. So instead of giving you sort of an inhibitory effect, it just blocks your excitatory effect. But ketamine also has an added effect, so it also exaggerates the release of catecholamines like epinephrine and dopamine, so it just makes the neurons spit out more of those hormones. And you'll remember that epinephrine and dopamine are what we learned about in vasopressors, right? So they increase your blood pressure, they increase your heart rate, and that sort of thing. So that's where you get that effect from. But the significance of it and why it's not always reliable is because sick patients often have already had this big release of catecholamines just simply by virtue of the fact that they're sick, right? They had an adrenaline rush, so they spat out all these catecholamines already. So if you have a patient that's already tachycardic or already hypertensive, when you give them ketamine, they don't really tend to get any worse. If you have a patient that's not sick and their heart rate and blood pressure is totally normal, then things will sometimes go up a little bit. But that's not usually an issue because hypertension and tachycardia just tend to be really transient. So some people will be cautious in the case of, SVT or paroxysmal AFib or something like that because you worry that like maybe you'll pop them into that arrhythmia. Or if you get somebody that's, really fragile and really elderly and you're worried that the extra blood pressure might give them an MI or push them into CHF or something like that, you might avoid ketamine there. But it tends not to be too much of a problem. And again, if somebody is really that fragile, maybe you shouldn't be sedating them at all. The significance of ketamine in head injuries and eye injuries has been debated quite a bit because that bump in sort of blood pressure might be something that increases your intracranial pressure. For a while, we thought that ketamine in itself might have increased the intracranial pressure via some other independent mechanism, and that's probably not the case. There's been some animal studies that show maybe, but human studies that show it doesn't. And so if it does do any sort of increase in intracranial pressure, it's probably related just to that brief hypertension, and it probably doesn't really matter. So we tend not to hesitate to use ketamine in head injuries. Intraocular pressure is another story. So it probably does do something to intraocular pressure beyond just playing with your blood pressure a little bit. So we try to avoid ketamine in glaucoma and eye injuries and that sort of thing. And the other interesting thing about ketamine and blood pressures and heart rates is that somebody decided that, if ketamine increases your blood pressure and propofol decreases your blood pressure, then could we mix them together in some sort of like super drug? And then ketofol was born. So ketofol is not a manufacturer prepared thing. It's a thing that you mix up, or it's just that combination of drugs that you give together. So an example of how you might use ketamine and propofol together would be like a little bit of ketamine at usually like a 0.5 mg per kg dose, and then you give an equal amount of propofol in kind of a 50-50 mix. And then if you need anything more than that, usually you top them up with propofol. It's interesting, and it's for a while it was a pretty popular combo because there is some research showing that people are less likely to get side effects from ketamine and less likely to get side effects from propofol. So it looks like a pretty good mix. The last drug I want to mention just briefly is etomidate. Etomidate is another induction agent that you can kind of think of as like propofol's cousin. It's got very similar kinetics, and you use it very much the same way, although it might be a little bit faster in terms of onset and offset. An example of how you'd use etomidate would be giving them, the same way as you do propofol, maybe 6 or 8 milligrams at that, 0.1 mg per kg dose. And then you just sort of top them up with units of 2 milligrams every 30 seconds or so. The interesting thing about etomidate, I guess, is that respiratory depression is probably about as common as propofol, but it seems to be very neutral in terms of hemodynamics. So it doesn't really affect their heart rate or their blood pressure in any way. I think the only reason we don't use this as much in Canada is because a lot of hospitals just don't have it. For a long time, it was a special access drug via Health Canada, and I don't know if that's still the case now, but there's not really a whole lot of people around here using it too much. So that's it pretty much for this talk. So just to summarize what we went over, remember again that sedation always carries risks of hypotension, of respiratory depression, and airway compromise. It's a problem with all of these medications to some extent. Midazolam and fentanyl is the classic combo that works really well, but the only problem is that it just lasts too long. Propofol is the most common agent that we use in sedation, and that's mostly just because it's so short-acting. You just got to make sure that you're playing with the dose appropriately. The usual advice is go slow, but don't go too slow with it, otherwise you're never going to get people to go down. Ketamine is the least likely out of all of these drugs to cause any sort of hemodynamic or respiratory compromise, but its kinetics are very different from all the other ones, so you got to be familiar with that and know how to use it. And just as a side note, etomidate's another drug you might see that's very, very similar to propofol, but it has a better hemodynamic profile, and its availability in Canadian hospitals is variable. So that's it for here. Our next talk is going to be on some of the complications associated with some of these drugs.